All right, good morning, everyone. It is my pleasure and honor to moderate this session today. And we have a great program for you today where we have multiple great speakers who are going to talk to us about different areas in advanced endoscopy. Our first speaker is going to be Dr. Andrew Lee. Dr. Lee is instructor of medicine. He's a fourth-year advanced endoscopy fellow. He's going to talk to us about post-ERCP pancreatitis and prevention. Dr. Nielsen Fernandez-Becker, she's an associate professor of medicine in our division, and she's going to talk to us about celiac disease and biopsy, if it's needed or not in celiac disease with a new advancement in diagnostic modalities. Then we'll move on to a talk by Dr. Mike Way, who's a clinical assistant professor. He's going to help us determine how we can reach the cecum in difficult cases. And after that, I'll be talking about EUS-guided pancreatic-biliary interventions, which focus on pancreatic collections and also on tissue acquisition and pancreatic solid lesions. And we'll move on to talk about third space endoscopy with Dr. Micaela Esquivel, who is assistant professor of surgery. And finally, we'll have Dr. Pradeep Siddappa, our third-year fellow in medicine, who's talk to us about optical-enhanced endoscopy or chromoendoscopy, when and where. Without further ado, I'll invite Dr. Andrew Lee to start his talk.
Good morning, everyone. I'm Andrew Lee. Dr. Eldika asked me to present some updates in post-ERCP pancreatitis. Well, perhaps not the most exciting topic. I think it's quite important with a couple of updates maybe to discuss. So by way of background, post-ERCP pancreatitis, as most of you know, is the most common and most feared adverse event following ERCP. It's also the most common serious adverse event in endoscopic procedures in general. It's a cause of significant morbidity and even mortality. And before we move forward, it's probably worthwhile reviewing the definition of post-ERCP pancreatitis. Asymptomatic elevations in pancreatic enzymes are quite common following ERCP, but post-ERCP pancreatitis, or PEP, is really defined by the combination of that combined with symptoms, namely abdominal pain. And based on this consensus definition by Cotton et al. 1991, the requirement of hospital admission or prolongation of an existing admission. So what are the mechanisms for post-ERCP pancreatitis? Post-ERCP pancreatitis arises from an initial injury, which sets off a pro-inflammatory cascade driven by cytokines and activated pancreatic enzymes. There are several proposed mechanisms for this initial injury. The first is mechanical injury, usually in the form of the manipulation of the ampular major papilla during cannulation. There's also mechanical injury through manipulation of the pancreatic duct, whether it's wire passage or with passage of instruments in the main pancreatic duct. Thermal injuries is another important factor, usually in the form of electrosurgical device being used to perform a sphincterotomy. And finally, hydrostatic injury, usually in the form of contrast injection or pancreatoscopy with if saline is used. Risk factors for post-ERCP pancreatitis include procedural-related factors as well as patient-related factors. Most of the procedure-related factors center around, again, prolonged manipulation of the major papilla, so difficult cannulation, repeated guide wire passage into the main pancreatic duct, injection, balloon dilation of an intact biliary sphincter, and ampulectomy. In terms of patient-related factors, female sex, younger age, history of prior post-ERCP pancreatitis, and SOD are known risk factors. So with this in mind, what steps can you take to reduce the likelihood of post-ERCP pancreatitis? I think step 0 is really having an appropriate indication for ERCP. I think before taking a patient to ERCP, you should really ask yourself the question of, can this question be answered with a less invasive, less risky approach? And there's a pretty exhaustive list of indications for ERCP shown here on the left of the screen. It's certainly not entirely exhaustive, but you can see that there are a lot of indications. And so if you're outside of this list, you should, again, ask yourself, could, for example, cross-sectional imaging or EUS answer the question without going to ERCP? So if you're intermediate risk, for example, for choledocholithiasis, could an MRCP or EUS answer the question for if there's a stone or not? And by the same token, if there's a question of, there's biliary dilation, is there a question of stricture or not? Is it worthwhile, for example, getting MRI or doing an EUS beforehand and answering that question without subjecting the patient or exposing them to the risk of post-ERCP pancreatitis? With that said, I think I'm going to spend the majority of the rest of this talk really reviewing probably the most, salient updates in the prevention of post-ERCP pancreatitis, and that's in the form of these guidelines published by the ASGE about 2 months ago. They performed a systematic review and meta-analysis of many dozens of trials answering 5 specific questions, which we'll go through, and I think this is probably the most up-to-date and kind of comprehensive overview of kind of the current state of prevention of post-ERCP pancreatitis. So the first question they looked at was the use of rectal NSAIDs. So the recommendation put forth by the ASGE is that for both unselected patients and high-risk patients undergoing ERCP, pre-procedural rectal NSAIDs should be given. And we'll go through the evidence for both of these recommendations. So for all patients, so these are unselected patients, in their systematic review meta-analysis, there were 18 trials included of about 4,800 patients. In terms of the NSAIDs that were studied in these randomized controlled trials, they include diclofenac, indomethacin, among others. And a couple of exclusion criteria to note, it's as you would expect for NSAIDs. So renal insufficiency, NSAID allergy, active peptic ulcer disease, and in most trials, if there was ongoing acute pancreatitis, they were excluded as well. Rectal NSAIDs were associated with a significant relative risk reduction by about 50%, with an incidence of post-ERCP pancreatitis about 7% in the NSAID group versus about 13.5% in the placebo group. There was a trend towards a reduction of moderately severe or severe pancreatitis as defined by kind of the, in most studies, the Cotton consensus criteria. But this was not significant. And one thing I'll note here is that most of the RCTs that were included in this systematic review meta-analysis excluded very low-risk ERCP procedures such as biliary stent exchange. So this is something to take with a grain of salt, I think. They did do a sub-analysis for timing of rectal NSAIDs, whether it's given 30 minutes before the procedure or within 30 minutes of procedure. There was no difference. There's also some trials that looked at NSAIDs given after the procedure, and it seems like all of these are acceptable methods or acceptable timing for administration of rectal NSAIDs. And finally, in terms of the question of adverse events potentially associated with rectal NSAIDs, there was no difference in renal failure or GI hemorrhage. Among high-risk patients, and the way high-risk patients was defined was basically up to the individual RCTs. Common inclusion criteria for high-risk patients include female, age lower than 40, normal bilirubin, suspicion of SOD, and kind of the older studies and the more recent studies, most of the criteria center around difficult or prolonged cannulation, for example, precut sphincterotomy or cannulation attempts greater than 5 or greater than 10 minutes. In this population, rectal NSAIDs were associated with significant reduction in risk of post-ERCP pancreatitis, again, an odds ratio of about 50%. And again, a trend towards a lower risk of moderate or severe post-ERCP pancreatitis, but not significant. One thing that the ASGE does note in these guidelines is that it was a little bit unclear what the effect of NSAIDs is separate of pancreatic duct stents, as these were left up to the discretion of the performing endoscopists in the vast majority of trials, and in some of these trials, up to 80% of patients in this high-risk group did have a pancreatic duct stent placed. And so it's a little bit unknown what the effect of NSAIDs is in high-risk patients. if no PD stent is placed. There's a lot of heterogeneity in these trials that I'll point out here, and that's in part due to the varying definitions of what constitutes a high-risk patient. And in the older trials, most of these are related to, again, SOD, and more recent trials, difficult cannulation. In terms of cannulation approach, the ASG recommends guidewire cannulation over contrast-guided cannulation. So contrast-guided cannulation is basically defined as the use of injection of contrast at any point during the procedure at the level of the major papilla. Guidewire cannulation is defined as simply using guidewire to confirm whether biliary or pancreatic access without the use of any contrast. In this systematic meta-analysis, 15 RCTs were included. A relative risk reduction of 50% was found. No difference, again, in moderately severe or severe pancreatitis, and no difference in terms of adverse events. They do note that there is some variation in terms of different techniques for guidewire cannulation, the first being very superficial engagement with a sphincterotome, followed by wire passage, and then advancing your sphincterotome or cannula over the wire. The latter is sinking your sphincterotome or cannula into the duct of choice and then placing the wire to confirm which duct you're in. And the latter of these is associated with perhaps a little bit more of a relative risk reduction, 0.3 versus 0.66. In high-risk patients, pancreatic stents are recommended by the ASGE, and in particular, what they suggest here is for patients undergoing ampulectomy, pre-cut sphincterotomy, history of post-ERCP pancreatitis, difficult cannulation, provided that PD access can be easily achieved. In high-risk patients, again defined by the authors of the individual RCTs, PD stents were associated with a reduced risk of relative risk about odds ratio of 0.38. And this was the only intervention among the 5 questions asked that did reduce the occurrence of moderately severe post-ERCP pancreatitis and severe post-ERCP pancreatitis. And in particular, there was a striking finding of a 0% incidence of severe post-ERCP pancreatitis if a PD stent was placed in high-risk patients, compared to 1% with no stent. They did a sub-analysis for how and when PD stents were placed, and this finding held true for if a PD stent was placed, if there was existing wire access to the PD, or if an additional step was taken at the end of the procedure to place a wire into the PD in order to place the stent. So this is recommended as a strong recommendation in ampulectomy and conditional recommendation for high-risk patients, that so long as you can easily get access to the pancreatic duct, a pancreatic duct stent should be placed. The final question that they visited here was the use of intravenous hydration. So in most protocols studying this, it's a bolus of 20 cc's per kilogram followed by an 8-hour infusion. There have been 2 other studies that look at a slightly different protocol. One is 24 hours, one is 2.5 hours, but for the most part, it's an 8-hour protocol. And based on the systematic review meta-analysis, the ASG recommends on a conditional basis intravenous hydration for all unselected patients undergoing ERCP. One thing I'll note, however, is that the inclusion criteria for 10 of the 12 RCTs used in this study required the presence of a native papilla, so in some sense, this is not truly an unselected population. It is perhaps a little bit more of a higher risk population. But nonetheless, they did find about, again, a 50% reduction in the risk of pancreatitis. There was no significant difference in volume overload. These trials, for the most part, excluded patients with known renal insufficiency, heart failure, et cetera. The practicality of this recommendation for outpatients is maybe a little bit challenging. An 8-hour infusion in the PACU logistically challenging. So for the most part, I think most of these studies occurred in the inpatient setting, but there is work looking at shorter hydration protocols now. This is a segue into kind of future directions, existing trials that are ongoing for example, combination therapy, combining NSAID with hydration, NSAID with pancreatic duct stents. Not mentioned in this slide are other agents such as nitrates, tacrolimus, octreotide. And then finally, cannulation technique. As I mentioned before, what's the optimal method for guided cannulation? So in summary, preventive strategies for post-ERCP pancreatitis, I think first and foremost is appropriate patient selection, NSAIDs for all patients, especially high-risk ones. In terms of endoscopic techniques, guide wire cannulation rather than contrast-based cannulation, pancreatic stents in high-risk patients, and finally intravenous hydration. Thank you.
Good morning, everyone. Thank you for the organizers for inviting me to speak today. Okay, so today we will talk about celiac disease, and do we really need a biopsy to diagnose it? Okay, so before we get started, I just want to take a few minutes to just go over what celiac disease is. So in celiac disease, we have ingestion of a dietary protein in genetically predisposed individuals causes an inappropriate immune response that leads to inflammation, and that inflammation causes damage to the lining of the small intestine in what I call friendly fire. Now, just really quickly about the pathophysiology, if you guys remember, the small intestine is lined with intestinal epithelial cell layer, and it's organized in villi. And what happens with celiac disease is that gluten, which is represented by the green rectangle, gains access to the lamina propria where the immune compartment is. And what happens is that it gets modified by tissue transglutaminase and picked up by the antigen-presenting cells and activating the immune response. And this leads to several things. One is the activation of CD4 cells, which cause production of cytokines that further increase the permeability of the barrier. The second is the CD8 cells are activated, and this leads to cells, those IELs that cause apoptosis of the intestinal epithelial cells, and it's one of the mechanisms of mucosal injury. And finally, B cells are activated, and antibodies are made against gluten and against tissue transglutaminase. And the reason I'm going over this is because this is the basis of the diagnosis. We look for the antibodies that tell us that there's immune reactivity, and also the hallmark of celiac disease is mucosal injury, so we rely on biopsies for that. And this may be familiar to all of you. On the left-hand side, you have a normal mucosa, which the folds are very nice and delicate. And on the right side, you have mucosa where there's an enteropathy, and you see nodularity and some scalloping. It's a very highly prevalent disease. The estimated prevalence is 1% worldwide. And we've gotten better over the years at making the diagnosis. However, there's still significant numbers of patients that remain to be diagnosed. So there's always a push to try to be better at making the diagnosis. Obviously, the treatment is gluten exclusion, where we exclude products made from wheat, barley, and rye. And this requires that the patient learn the gluten-free diet in depth. Then they have to implement it, and then they have to maintain it. And the gluten-free diet requires lifelong commitment. It's cumbersome, it's expensive, and it could adversely affect the quality of life. So we want to make an accurate diagnosis, one, to prevent celiac complications, and also it has implications for testing for the family. And an inaccurate diagnosis will falsely impose the burden of a gluten-free diet unnecessarily. There are several diagnostic tests that are available. that we use in different contexts. So we will go over the genetic tests, serologic testing, and in the role of intestinal biopsy. So first, genetic testing for HLA-DQ2 and DQ8, which is incredibly common in the age of 23andMe. And the story is that these genes are present in 99% of patients, over 99% of patients with celiac disease. When you look at the general population, about 40% of individuals carry HLA-DQ2 or DQ8, but it's really a small minority in the order of 2 to 5% who go on to develop celiac disease. And clearly there are other factors. There are environmental factors, other genetic factors that play a role. This is very helpful in patients who are already on a gluten-free diet because of its excellent negative predictive value. So basically, if the patients don't carry these genes, it's highly, highly unlikely that they will develop celiac disease. Whenever we have a suspicion for celiac disease, our preferred test for screening is serology. And specifically, it's serology tissue transglutaminase IgA. Those are those antibodies that are made when the patient is exposed to gluten. And basically, one thing that I will say is that it is also recommended to test an IgA, total IgA, because about 2% of patients with celiac disease have IgA deficiency, in which case these antibodies would not be reliable. And we often use other antibodies, such as anti-deaminated gliadin peptide or anti-endomysial antibody in different contexts, if there's a question of the diagnosis or if the tissue transglutaminase is negative and we still have high suspicion. One thing that I will say is that there's a lot of different assays out there for tissue transglutaminase, and the normal ranges vary. They don't all perform the same, which adds to the complexity of making a diagnosis. And then there's the intestinal biopsy. So if we have a positive TTG, or if it's negative and we still have a high clinical suspicion for celiac disease, we rely on biopsy. On the top panel, you see that, that capsule endoscopy image of a normal lumen. And alongside it is normal histology, where you see very nice, tall, tapery villi and compact crypts. And the villi should be at least 2.5 times taller than the depth of the crypt. In the bottom, what you see is it's a significant enteropathy. In histology, you see that there's a lot more inflammation. The crypts are very deep, and the villi are gone. There are ways to grade the severity of the inflammation, and the most common is the Marsh criteria that's shown here, and this relies on looking at the morphology of the villi, how tall the villi are, the depth of the crypt, and the presence of intestinal epithelial lymphocytes. Okay, so this is a busy slide, and I'm not going to go the entire algorithm. The purpose of this is to show that so first, if the patient's on a gluten-free diet, HLA typing is helpful because it could help you decide whether to do a gluten challenge or to exclude celiac disease. But the bottom line is that if the serologies are positive and there is clinical suspicion for celiac disease or intestinal disease, we recommend biopsy, except in right here, the children, where there's a non-biopsy criteria that has been employed in Europe and in a case-by-case basis in the United States. So because of the disease burden and the fact that there are some detractors to biopsy, there has been a movement towards developing non-biopsy diagnosis in adults. So this leads me to go over what the pros and the cons of doing biopsies are. The advantages are obviously that we could look at the severity of the mucosal injury and we could establish a baseline. It can potentially lead to a more accurate diagnosis because histologically we could actually distinguish celiac disease from other enteropathies. And this may reassure the patient so they buy into the gluten-free diet more. And also in adults, celiac disease is a common disease and it coexists with a lot of other things. So it allows for diagnosis of comorbid conditions. The disadvantages is that it is expensive. The procedure risk, along with the anesthesia risk, also adds to the detractors. And in children, these procedures are usually done with general anesthesia, which increases the risk. One could argue also there's a variability in identifying the celiac histologic changes. And this could be because of the nature of the disease, given that it's patchy, but it also could be due to the expertise in the path lab. So in Europe in 2012, the Pediatric European Society of Gastroenterology, Hepatology, and Nutrition came up with guidelines that allowed for biopsy-free diagnosis of celiac disease in children. And here, symptoms suggestive of celiac disease, particular malabsorption, was required. The serum tissue transglutaminase of 10 times upper the limit of normal, positive anti-endomysial antibody, positive HLA, DQ2, DQ8, and the patient and the parents have to be okay with this approach. These were updated, and the presence, well, the genes are still there, it's just that you don't have to check them. But the presence of symptoms was no longer obligatory. Now, and I will say that this has not been adopted in North America. I would say that over the years, people have looked at what is the relationship of TTG and the diagnosis of celiac disease in symptomatic adults, and several observations here that I would like to point to. One is that the higher the titer of TTG, the more accurate it is to make the diagnosis. Because there's different assays in different kits out there, abnormal values vary depending on the assay, and they should be looked at, so the local values should be applied. And the figure on the left here is an interesting study where they actually sent off the blood of a patient with patients who had positive TTG and used many different assays, and as you can see, the normal range vary significantly. In one study center, they showed that 2/3 of the patients that were diagnosed, not rigorously, but based on biopsy, had the wrong diagnosis. Combining tissue transglutaminase with other serology improves the diagnosis. But studies do show that there is promise to a biopsy-free biopsy in symptomatic adults, similar to pediatrics. And some studies do suggest that maybe increasing that to 16 times the upper limit of normal may increase specificity. I'm just going to quickly go over two studies that looked at applying the pediatric guidelines to adults. And in one single center study, they looked at two cohorts. Highly suspicious for celiac disease, people who had serologies, who had symptoms typical of celiac, and people with moderate suspicion. These are the family members of patients with celiac disease. And what they found was that when they applied the 10 times upper limit of normal, the positive predictive value was quite high. I mean, it was 100%. So it didn't miss the diagnosis. However, if you only looked at just any positivity, or just barely positive, then that positive predictive value varied from 84 to 100%. So you could falsely diagnose more patients with celiac disease. And the study did suggest that perhaps 10 times up the limit of normal was too high, and maybe the biopsy omitting threshold could be lower. Okay, and the other study was a multinational study. And they had three cohorts, one high suspicion for celiac disease and the other low suspicion, which was patients who were referred for endoscopy but did not have risk factors for celiac disease. And there was also a retrospective study in 8 different countries and 11 different labs. And in both cohort 1 and 2, the positive predictive value was quite high, 98 and 100. But when you look at cohort 3, where we're dealing with different assays, different labs, that positive predictive value was 95, and which means that 1 out of 20 patients could be misdiagnosed with celiac disease. So what are the potential pitfalls of having a biopsy-free approach? One is the specificity of serology means that some will be misdiagnosed. And we have to decide whether that's appropriate or not. Different assays may perform differently. Criteria have to be applied rigorously because less application will lead to more false positives. Persistent symptoms, despite gluten-free diet, and persistent mucosal injury is common in adults, so it's difficult to assess degree of mucosal healing if we don't have a baseline. We can miss comorbid conditions. Serology, 10 times upper limit of normal, 100 positive predictive value, but as we know, many of the patients that we take care of are already on a gluten-free diet, so these will not apply very well. Anti-endometrial antibody is not readily available, and diagnostic yield is variable depending on expertise, so we may have to rely on just one serology. And finally, there's the population of potential celiacs who have positive serology but don't have mucosal injury, and there's some controversy as to who needs to be on a gluten-free diet. So in summary, 10 times upper limit of normal is highly suggestive of celiac disease, that we can say. There's lack of standardization of commercially available TTG assays that makes serologic diagnosis more difficult. It's debated whether a false positive rate is acceptable. Endoscopic risk is lower in adults than in children due to the less need for anesthesia, but there are situations where the biopsy-free approach may be more acceptable in the instances where the risk of biopsy is unacceptably high. So it's nice to have an alternative. And biopsy-free diagnosis has not been adopted in the diagnostic guidelines as of yet, and there is fervent support for the biopsy in the US. And the bottom line is that I do think that there's still value to a diagnostic biopsy. Thank you so much.
Hello, everyone. I'm Mike. Thanks for the organizers for having me. And so today we'll be talking about cannot make it to the cecum. How can we help? So the ASG and the ACG recommend that for all colonoscopies, there's a cecal intubation rate of 90%, and for screening colonoscopies, this rate is 95%. However, during the course of endoscopy, all of the endoscopists here in the room are inevitably eventually faced with a difficult colonoscopy where it is troublesome or challenging to reach cecum. In some cases, cecum is actually not reached, which we would then define as an incomplete colonoscopy. Several studies have been looking at factors for difficult colonoscopy, and specifically looking at what are increasing cecal intubation rate as a surrogate for difficult colonoscopy. And factors that have been identified have included female sex, inadequate bowel preparation, older age, constipation, lower BMI, patient pain, previous hysterectomy, and diverticular disease in women. Studies looking at factors for incomplete colonoscopy are significantly more sparse, and I think partly this is just because the numbers are also significantly fewer. There are 2 main studies that I wanted to focus on. One by Koido in 2014, looking at 11,800 patients who underwent colonoscopy in Jutendo Hospital in Tokyo, and found that cecal intubation was 95%. And risk factors were rather similar to the previous slide, but included female sex, history of prior abdominal or pelvic surgery, increased age, IBD, poor bowel preparation. Shah then followed up with a study in 2007 looking at 311,000 colonoscopies that were performed through the Ontario Health Insurance Plan and found 13.1% incomplete colonoscopies. Factors here included older age, female sex, prior belly surgery. In addition, they found that colonoscopies performed at a private center had increased odds of incomplete colonoscopy compared to when it was performed at an academic hospital with odds ratio of 3.6. Whenever we perform colonoscopy, I think it's always important that an endoscopist tries to optimize their technique. And an endoscopist's career, I think, is with this continual growth of trying to figure out what their best technique can be and trying to figure out how they can continue to improve. But the main pillars that we think about are minimized looping, minimal insufflation, sufficient sedation, and utilizing abdominal splinting when needed. When we have difficulty reaching the cecum, we tend to think about 4 different types of problems. There's inadequate sedation, redundant or looped colon, tortuous anatomy, or presence of hernia. All of us may be familiar with this, but during colonoscopy, when a patient starts clenching down their abdominal wall, they start grimacing, it ends up being very, very difficult to be able to advance the colonoscope. During this case, then we think about trying to increase sedation or in sometimes rescheduling to have this done under deep sedation or monitored anesthesia care. When we encounter the redundant or looped colon, we usually think about utilizing an adult colonoscope, which is in comparison to a pediatric colonoscope, and definitely have our staff help us with abdominal pressure. When we encounter tortuous anatomy, in this case, pediatric colonoscope actually may be superior to an adult colonoscope, or sometimes we also utilize an enteroscope or a ultra-thin colonoscope. Finally, in the presence of hernia, we think about 2 types of hernias. There's the abdominal hernia as well as inguinal hernia. In both of these cases, having abdominal pressure ends up being important. Actually, in all of these cases, we actually think about having water immersion as well as water exchange. And so during water immersion, colon is immersed with water rather than air insufflation or carbon dioxide insufflation. The one study that looked at this was back in 2012 by Veramapalli as well as Dr. Rex, who performed a retrospective study evaluating 345 patients that were referred for incomplete colonoscopy. All of these colonoscopies were performed by the famous Dr. Rex, and they found that cecal intubation was similar for both water immersion as well as for gas insufflation. When they looked at overtube technology or positional change, they found that when water immersion was performed, then overtube was utilized in 3% compared to during gas inflation of 15%. Positional change was required in 7% of water immersion compared to 16% in non-water immersion. This was not statistically significant, but when they looked at patients who had redundant colons, both of these factors ended up being statistically significant. So what happens when we have tried optical technique and we still are stuck? Under these circumstances, then I think it's important that we think about additional tools or devices. The first that we start with is the ultra-thin colonoscope. In 2017, Emoto performed a randomized controlled trial looking at the ultra-thin colonoscope, which is the EC530XP 7mm diameter scope by Fujifilm, which is actually not available commercially, and find that compared to pediatric colonoscope, they were able to achieve lower pain as well as improved cecal intubation for female patients 70 years or older. Ito performed a study looking at stenotic colorectal cancer that could not be traversed by pediatric colonoscope and found that by using an ultra-thin colonoscope, they were able to achieve cecal intubation at 58%. This was utilizing the Olympus PCF PQ260L, which is 9 millimeters in diameter. This has similarly been demonstrated in Crohn's strictures. The reason I bring up the actual names of these devices are because there are only 3 main ultra-thin colonoscopes that we utilize. The PCF PQ260L, the PCF PH190L, which is the one that we utilize at Stanford, and then there's the EC769P at Fujifilm. Single balloon on the left and double balloon enteroscopy have been utilized in evaluating small bowel, but it can actually also be used in difficult colonoscopy. And so the way this ends up working is the presence of the balloon allows for pleating of the colon as well as stabilizing the colon, allowing the enteroscope to be advanced. Despin 2017 performed a randomized controlled trial looking at difficult colonoscopy, which is predefined by a few different criteria, and randomized patients to double balloon to conventional colonoscopy. They found that double balloon colonoscopy achieved similar cecal intubation time, but patients had improved patient discomfort as well as pain scores. In a meta-analysis performed by TAN, looking at single balloon and double balloon enteroscopy, there was similar cecal intubation rate around 97%, as well as similar time to cecum. In a variation in the theme of overtubes, the originalizing overtube, which is the Pathfinder endoscope overtube, was approved by the FDA in August 2019. So the overtube comes in 2 primary sizes, 85 centimeters as 110 centimeters, and it is able to switch from flexible to rigid with the application of a vacuum. The ways this works is during endoscopy, when you reach an area of interest and then you've reduced the colon as much as possible, then you reduce the scope as much as possible, then you advance the overtube, and you switch on the vacuum, allowing for a rigidization of the overtube up to 15 times. This helps prevent looping from forming as you then advance the colonoscope. In one case series that we performed here at Stanford and as well as the VA Palo Alto, we looked at 12 patients with incomplete colonoscopy. In all these cases, with the utilization of the rigidizing overtube, we were able to achieve cecal intubation and were able to achieve median cecal time of 6 minutes. The GI colonoscope by Smart Medical involves the remanufacturing of a reusable balloon at the bending section of the colonoscope. The balloon can be inflated and deflated using their Spark-C inflation system, which then allows for more controlled maneuvering around folds. While this seems like it will help, there actually are no specific studies looking at this in the context of incomplete colonoscopy. The sister product of this is the NaviAid AB device, which is a through-the-scope inflatable balloon. Ali in 2015 looked at NaviAid AB in the context of enteroscopy, and in 33 retrograde cases, they were actually able to achieve a depth of insertion of 89 centimeters proximal to the ileocecal valve. In an unpublished study, which remains in abstract form, looking at 9 patients in incomplete colonoscopy, NaviAid AB device was able to lead to completion of all colonoscopies. Given the importance of abdominal compression, unfortunately, the huge burden on our staff, we think about abdominal compression devices to try to help, and this is the ColoWrap device, which has been found to assist with decreasing cecal intubation time and improve the need for additional manual compression. Similarly, this product has not been specifically studied in the context of incomplete colonoscopy. In 1994, Kasman described the technique of colonoscopy over the forceps, and in this concept, the forceps is advanced beyond the scope, 10 centimeters beyond, and then with a little bit of tension on the wire, the scope is then wiggled forward. In a variation on this idea, Zutron Medical came up with a stiffening wire. In a randomized controlled trial looking at the standard stiffening wire, the firm stiffening wire, as well as without the use of the wire, there was no significant difference in cecal intubation. However, when they looked at the unaided colonoscope that was unable to reach cecum, they then utilized the stiffening or the firm or the regular stiffening wire. They found that they could improve cecal intubation from 81% to 97%. So what happens if the cecum still cannot be reached? Dr. Goldenberg briefly touched on this yesterday, but we can think about the utility of CT colonography or colon capsule colonography. Similar to the work that Dr. Goldenberg had presented, the randomized controlled trial by Sali had compared CT colonography compared to 3 rounds of FIT performed every 2 years. And while there was low participation overall for CT colonography, as well as all 3 rounds of FIT, advanced neoplasia was detected at greater percentage for CT colonography compared to FIT. In a meta-analysis by Detting, looking at CT colonography compared to colon capsule colonography, CT colonography was able to have higher completion rate, but colon capsule endoscopy was able to have increased detection of polyps of any size at 37% compared to 10%. In our experience, we tried to understand the issue at hand. In our particular case, we have a very great referral base of very experienced endoscopists who actually are very commonly document exactly the specifics of the problems that lead to their incomplete colonoscopy. And we use that information to try to tackle the colonoscopy appropriately. If the patient failed colonoscopy due to patient intolerance, then we try to have the patient done under deep sedation monitored anesthesia care. If tortuous colon was identified, then we start with the pediatric colonoscope. At times, we will use the ultra-thin colonoscope or even the upper endoscope, with the upper endoscope obviously being less preferred given its shorter length. If there was significant looping, we have our most experienced staff help us with our splinting, and we consider use of the overtube technology. So this would be the single balloon or double balloon enteroscopy or the rigidizing overtube. In all these cases, we utilize underwater immersion. So in conclusion, in all colonoscopies, we recommend optimizing technique with minimizing insufflation, with optimizing sedation, optimizing belly pressure, and minimizing looping. When the cecum cannot be reached, despite optimal technique, we consider utilization of additional tools, including the overtube, as well as specialized endoscopes, such as the ultra-thin colonoscope. If this remains still unsuccessful, then we consider use of non-invasive imaging in the context of CT colonography or colon capsule endoscopy. Thank you.
All right, switching gears to EUS. So over the past 15 years, endoscopic ultrasound had made a big leap from just being a diagnostic imaging modality to tissue acquisition and eventually to interventions in mostly in pancreatic-biliary disorders. So during this talk, I'll talk specifically about EUS intervention in pancreatic fluid collections, mostly in walled-off pancreatic necrosis, and we'll also touch base on EUS-guided gallbladder drainage, and finally, what's the updates in relation to tissue acquisition in pancreatic solid lesions. So we had multiple studies and randomized controlled trials that have shown that using EUS intervention in drainage of pancreatic pseudocysts is more effective than even minimally invasive surgery. And there is also many trials that have shown that EUS intervention in walled-off pancreatic necrosis is superior to minimally invasive surgery in respect to outcomes. When we are doing drainage of pancreatic fluid collection, the question arises, are we going to use lumen-opposing metal stent, or we have to stick to the old modality of using double pigtail stents? Is there a difference or an advantage of lumen-opposing metal stents in these situations? And there is a meta-analysis of 30 studies, including one randomized trial that have shown that there's no difference in adverse events between the two modalities of bleeding or perforation, and also in the outcome where walled-off necrosis resolution was similar between the two modalities, number of procedures to achieve resolution of the necrosome from the collection was similar between the two modalities, as well as stent migration and stent inclusion. So in this meta-analysis, it's showing that there is no difference. So why everybody is using a lumen-opposing metal stent to gain access to the fluid collection and perform the intervention to clear the fluid collection from the necrosome? The reason for that is most of these studies have used the old type lumen-opposing metal stent, where it didn't have electro-enhanced activity that allows quick entrance into the cavity. With the new type of lumen-opposing metal stents that are electro-enhanced, you can directly access the cavity and spare many different steps that include using a needle, dilating the tract, and risking perforation. So it is more efficient in respect to time to use lumen-opposing metal stent in order to gain access and do the intervention to clean the cavity. The other question that gets raised in these situations is early intervention. There's a difference between early intervention less than 4 weeks after the presentation of the patient with pancreatitis versus waiting 4 weeks when the collection is more organized, and in the case of necrotic material, is it walled-off necrosis. So this is a meta-analysis that looked into that, and the findings did not show much difference in respect to adverse events. However, early interventions were associated with high mortality rates. So like the bleeding, the perforation was not different between the two groups, but early intervention was associated with more mortality, with higher mortality compared to delayed intervention when the collection is more organized and ready to be drained and intervened on. So it is important to wait for about 4 weeks for these collections to organize. But if it's needed, if the patient is unstable, and if it's needed to intervene, then catheter drainage using percutaneous drainage is the best approach until the collection is ready to be drained transmurally. So here you can see from these pictures the pressure of the collection on the stomach, and this is gaining access with the lumen-opposing metal stent. And you know, we used to do more of cleaning with stiff snares to get the necrosome out of the cavity, like you see here, dark material here, the necrosome, getting it out to the stomach, and then clearing the cavity from all the necrotic material. But lately, there is a new technology that was introduced that represents this catheter. It's called an Moderator, and it has this spinning, knife in the middle, and it's connected to suction. So the knife spins at a rate of more than 1,500 RPM, and at the same time, it suctions the fluid into the space here and cut it and eventually suction it up. So this is, there is a study that looked into the effectiveness of this technology in cleaning the cavity that used to take, I mean, it can take, hours to clean the cavity if you want to do it in one session using the snares or other modalities, and many times require multiple different sessions using these snares. So with the introduction of this, and in this study, the procedure time was about 117 minutes, and 50% of the cases had complete debridement from one session, and 73% had complete debridement in 2 sessions. And these were really large collections that were used. In this study, they used a 3.1 millimeter catheter. Currently, there is a 5.1 millimeter catheter that is more effective in treating these collections. And this is a study that included our center. It's still an abstract form. Included 23 patients with 32 procedures. And again, 50% of the content of necrosum was able to be cleared with one session. And for those cases that had only the endorotor as a modality of intervention and clearing of the cavity, an average of 2 sessions were required to complete the debridement. So this is a video showing the use of the 5.1 millimeter catheter. The catheter is spinning and suctioning the necrotic material, as you can see here. Very effective in clearing and suctioning instead of using the snare. A lot of times during these procedures, you are going to use this modality along with the snare as well, especially when you get to the point where there is very little necrotic material left. Here you can see after completion of the debridement, you can see the cavity is clear. You can remove the lumen opposing metal stent and leave the plastic stents in place after completion. Lumen opposing metal stent placement doesn't go without potential complications, and this is a meta-analysis that included several studies, and the complications from placing these stents can range from bleeding, stent migration, infection, and stent occlusion. Severe complications are rare, but most of these complications were managed either with endoscopic reintervention or with placement of percutaneous catheters. To decrease the complication rate from these procedures, there are certain maneuvers we can do to decrease that. And one of them is when you place initially the lumen opposing metal stent, we dilate the track, because when you place it, the stent is not fully open. Dilating the track has been shown to decrease the risk of complications and mostly infection from occlusion of the stent after placement. The other thing you can do to decrease the risk of complication is placing a double pigtail plastic stents coaxially into the lumen opposing metal stent, and that have shown to decrease the adverse event, and specifically stent occlusion and patient presenting with infection by more than 50%. Moving to EUS-guided gallbladder drainage, there are so many different indications for that, and currently what we do most of the time before introduction of this technology, percutaneous drainage was used to drain the gallbladder in patients who are high risk for surgical intervention. But recently we have the introduction of EUS-guided gallbladder drainage to drain the gallbladder. And this is a randomized trial of 80 patients that compared EUS drainage versus percutaneous drainage, and all the outcomes were superior in favor of EUS-guided drainage. As you can see with recurrent cholecystitis, 2.6% in cases of EUS-guided gallbladder drainage compared to 20% in the case of percutaneous drainage. Again, this intervention is in patients who are not who are at high risk for surgical intervention. So in this study, the predictor for recurrent acute cholecystitis was the performance of percutaneous drainage. This is a study that looked at prophylactic use of EUS in drainage of the gallbladder in patients who have malignant obstruction of the bile duct and also involvement of the cystic duct. And for patients who had prophylactic placement of a stent to drain the gallbladder endoscopically, 0 of these patients had cholecystitis compared to 23% of patients who didn't have placement prophylactic lumen opposing metal stent. So this is a video showing the drainage of the gallbladder. You can see here you have the bundle of vessels that decided to be in our way, so trying to avoid that. And here you have the lumen opposing metal stent getting ready to enter the gallbladder. This is the advancement of the stent and then deployment of the distal flange inside the gallbladder lumen, and then pulling the distal flange towards the wall, and eventually deploying the proximal part of the stent into the duodenal bulb wall, and then drainage of bile with some streaks of pus. Moving to EUS-guided fine needle biopsy, do we need rows when we're using EUS fine needle biopsies? We moved to using these biopsy needles instead of using fine needle aspiration. And in this randomized controlled trial, it didn't show that there is a difference in respect to accuracy between using, biopsy a needle with or without rows. Rows is rapid on-site evaluation where you have the cytopathologist coming down and giving you idea of if you have adequate sample or not. So when you're using fine needle biopsies, you don't need rows. And as you can see, what's interesting is that tissue core was more when you don't have rows available. The reason for that is we have more tissue available for cell block and not used for smear formation. This is a study looking at different types of needle, and what's shown in this study is that 22 gauge Francine needle or fork tip needles are superior to other type of needles like side hole biopsy needles or fine needle aspirations. They are superior in respect to accuracy. So none of these needles were significantly different from each other when you have rows available, and that's again in respect to accuracy. This is a recent study looking at the biopsy needles when you're trying to give the oncologist genetic profiling and or molecular profiling that's been used for precision medicine in order to guide chemotherapy. And it's been shown in this study that you can get adequate sample for these studies, for these studies to guide chemotherapy by just doing 2 passes with the biopsy needle and no need to do more than that. So in conclusion, EUS superior to surgery for pancreatic fluid collection drainage. A drainage should be attempted after 4 weeks unless patient shows persistent instability despite antibiotics. Drainage with double pigtail stents is comparable to lumen opposing metal stents. However, the deployment of lumen opposing metal stent is easier and prevent many different steps that can cause complications and prolong the procedure. Powered endoscopic debridement is a promising new debridement technology using the endorotor, especially with the large endorotor. Lamps need to be removed within 3 to 4 weeks of placement, decrease complication rate, especially bleeding. Balloon dilation of the lumina posing metal stent, and placing a double pigtail stent coaxially decreased adverse events. EUS gallbladder drainage in high-risk patients is superior to percutaneous drainage. And when using biopsy needles for solid pancreatic masses, ROSE is not required. And Francine and fork-tip biopsy needles are superior to other type of needles. Thank you.
Okay, great, thank you. Hi, everybody. Again, my name is Micaela Esquivel. I'm one of the minimally invasive bariatric and endoscopic surgeons here at Stanford. Very happy to be here. Today, I'll be talking about third space endoscopy, specifically focusing on POEM and G-POEM. I have no financial disclosures. So objectives for this talk is really just simply the why, the how, and the when. So we'll go over some outcomes, technical considerations, and specifically share how we approach these cases here at Stanford, and then some thoughts on best practices. So in terms of POEM, or per-oral endoscopic myotomy. This is an endoscopic procedure primarily used for the treatment of achalasia, where the inner circular muscle layer of the lower esophageal sphincter is cut through the submucosal tunnel. You'll have heard talks already about this from Dr. Clark and others, so I won't go into achalasia or other motility disorders, but mainly focus on the procedures themselves. So as you see through images A through F here, A is the mucosal lift, B shows the initiation of the submucosal tunnel in the mid to proximal esophagus. C demonstrates the progression of that submucosal tunnel, ideally 2 centimeters distal to the GE junction or into the gastric cardia. D demonstrates the initiation of the myotomy of those circular muscle fibers. And E demonstrates the progression and continuation of that myotomy, again, 2 centimeters distal to the GE junction. And F demonstrates that closure of the mucosal or the mucosotomy. So the why. Countless studies are continuing to come out more and more, but looking at some meta-analyses, we're getting longer-term data that shows that POEM has high efficacy. And compared to standards of care, pneumatic dilation, laparoscopic Heller myotomies with fundoplication, we have comparable, even higher efficacy rates. So it's been demonstrated time and time again, and now with some longer-term data, to be an effective treatment modality for achalasia and other esophageal motility disorders. And it's very safe. It's a safe procedure. So you see these potential early complications here, whether mucosal injury that's treated at the time of the POEM and identified, even esophageal perforation, bleeding, subcutaneous emphysema, and others. Vast majority of these do not actually require additional intervention, particularly when you successfully close that mucosotomy, making it air and liquid tight. And we see, this is under late complication, but a sequelae of POEM is a potential for reflux. And sometimes for these patients, they may not have symptoms. And so, some of these post-POEM patients do require ongoing surveillance. We do see that as well, even in our laparoscopic Heller myotomy patients with fundoplication, but something to consider. But again, overall, very safe. And again, most of these adverse events don't require an additional intervention, even more uncommon that they would need an operation. So now going into G-POEM, or gastric pearl endoscopic myotomy. It's an endoscopic myotomy of the pylorus, primarily for gastroparesis, also known kind of globally and broadly as POP as well, or per-oral pyloromyotomy. And looking at these images again from starting with A, we see our mucosal lift. B demonstrates the initiation of that submucosal tunnel, generally started in the antrum. We don't need to generally go quite as proximal as we do sometimes in the POEM. C demonstrates the continuation of that submucosal tunnel, really important that you know that you're post-pyloric. D demonstrates the retrograde pyloromyotomy, and then E demonstrates, again, that closure of the mucosotomy. So again, the why for G-POEM. So G-POEM's about 5 to 6 years newer than POEM, but again is demonstrating broadly that it's an effective treatment modality, but we're just working on some longer-term data, that's for sure. But again, looking at a meta-analysis, we found that 73 to 100% of patients have significantly improved symptoms. The symptoms that were most improved were nausea and vomiting across all these studies, while bloating and distension and abdominal distension seem to be less consistent, but there are several studies that show bloating is actually the symptom most responsive. I think you all heard talks from Dr. Linda Nguyen, Dr. Gottfried earlier regarding gastroparesis as well. Regardless of what symptoms specifically may be improved, the overall quality of life for these patients, for the vast majority of them, was significantly improved. In addition, in terms of healthcare utilization as well, post-POEM patients had a notable decrease in ED presentations, hospitalizations to manage symptoms of gastroparesis, as well as a decrease in antiemetic use and other medications. Now, when compared to laparoscopic pyloroplasty or robotic pyloroplasty, there were similar significant improvement of the GCSI scores for both modalities. So again, very comparable, whereas laparoscopic pyloroplasty was associated with longer procedure times, longer hospital stays. And when going into the safety, similar to POEM, it's an overall very safe procedure. There are a few serious adverse events and even fewer adverse events that might require intervention. And generally speaking, if they do, that would be primarily an endoscopic intervention, rarely surgical. Also important to note, because there are no incisions, multiple studies have shown actual comparison directly to laparoscopic pyloroplasty to have fewer adverse events due to not having the risk of surgical site infections. And several studies have shown higher risks of pneumonia for laparoscopic pyloromyotomy patients. So now we'll talk a little bit about the how and go over some technical considerations, starting with POEM. There's various approaches to achieve the same result. So I'm just going to share kind of how we approach these patients here at Stanford in our technical approach. But again, these patients are all intubated under general anesthesia. We don't currently routinely use the overtube for POEMs. We do for GPOEMs. We want our CO2 insufflation on the lowest setting throughout the duration of the procedure. And we want the smallest and lowest amount of indigo carmine with our saline solution. The lighter the blue, the easier to see vessels during the submucosal dissection. We use the Olympus H190 with cap for our POEMs with the newer ERB generator. We also routinely use the 16 centimeter EndoFlip catheter, both pre and post myotomy. And specifically, most frequently we use the hybrid type iKnife. It's this bottom one here. Kind of more needle-like, as you can inject, cut, and coagulate throughout the duration of the case without changing any sort of instruments. Also use the 4 millimeter coagulation grasper for any of those larger vessels throughout the submucosal tunnel, and then close that mucosotomy with several 11 millimeter short clips. And although we, showed the images previously in terms of the steps, all of this really relies on the initial endoscopic measurements in relation to the GE junction. And so you want those in the beginning during your screening endoscopy to identify where you want to plan your myotomy and your mucosotomy. But again, we start the saline lift and a longitudinal mucosotomy that you need to have 4 centimeters proximal to the planned myotomy. The myotomy should start at minimum 6 centimeters, 5 to 6 for type 1 and 2, proximal to the GE junction. And we do all of this kind of posteriorly at the 5 o'clock position, but this can be done circumferentially. So if there's been a prior POEM in that position, you can go anteriorly. Or if a patient's had a prior halar myotomy, you're not going to be at all in that anterior plane that was done surgically. And then continue that submucosal tunneling, as mentioned and shown in those images very nicely, that you do want to go onto the gastric cardia, ideally 2 centimeters distal to your GE junction. And again, you rely pretty heavily also on your pre-POEM measurements to confirm that you are doing just that. And then we complete the circular myotomy in an antegrade fashion with that hybrid I-type knife. So get under the circular muscle fibers, lift and progress from proximal to distal. And again, that mucosotomy closure is completed with those short clips. As mentioned, we do use EndoFlip routinely with our POEM cases, both pre and post myotomy. It can assist in confirming the length of myotomy needed, as well as confirm adequate distensibility and diameters post myotomy. So there are instances where we may not be satisfied post myotomy, might be surprised based off what things looked like endoluminally, and go back, try to dissect a little bit more, and at times do full thickness or longitudinal myotomy as well across the LES in those areas. And particularly for type 3 achalasia, use of the EndoFlip is extremely helpful, as we already know it's going to be a longer myotomy, but it can really help guide us in terms of where we want to start that myotomy in relationship to the LES. So for actual procedural planning, it's been quite helpful. And these are just images kind of showing what was described. So A, that mucosal lift, B, the mucosotomy, C, the submucosal tunnel, D, you see the circular muscle fibers in terms of the myotomy. You can see some cautery on the longitudinal, but then intact longitudinal muscular plane there, and then the clips showing that mucosotomy closure. Now for GPOEM, again, patients will be intubated on general anesthesia, will protect the airway. We do routinely use the overtube for this procedure. Again, low CO2 insufflation, same indica carmine mix, but we do use a larger scope more routinely. The stomach is a bit more vascular than the esophagus, and in terms of irrigation and insufflation during the duration of the procedure, that's something that has been helpful. Again, with the cap, same regenerator, and we do use a different type of knife. We use the triangle tip J knife most commonly, but there's numerous out there that basically give you kind of this hook, as this will be a retrograde myotomy. These can also inject and cut simultaneously as well. And again, the 4mm coagulation grasper. We do then switch to the 2T scope for the overstitch to close the mucosotomy. So again, this is generally on the greater curvature of the stomach. If a patient's had a prior GPOEM, they can have another GPOEM on the lesser curve. Of note, even post-GPOEM, we can do surgical pyloroplasties as well, even in a similar plane without difficulty. But important to note, again, saline lift and mucosotomy, we do this transversely. And you may see in a lot of literature the imaging longitudinal. I personally found that with the transverse, you don't start coursing down towards the pylorus, and so it really keeps that location of your mucosotomy. You don't end up extending unintentionally that longitudinal mucosotomy, because a little bit difference here is you can be closer to the pylorus here with your GPOEMs, because you're really just doing a pyloromyotomy. You're not extending the length of the esophageal muscle layer there. And then make sure that you're just past the pylorus, complete that retrograde full thickness pyloromyotomy, and then that mucosotomy closure. We suture to make sure that's air and liquid tight, but can use, and you will see broad use of the clips, and that's going to be more technically feasible with a longitudinal myotomy, more technically difficult with the transverse. Just in terms of our protocol, we do give IV antibiotics at induction. We do admit our patients to observation overnight, get a swallow study post-procedure day 1 in the morning, then discharge once tolerating a full liquid diet that post-procedure day 1. And then depending on kind of symptom profile, type of achalasia, dilation of the esophagus, patients are generally on a full liquid diet for 3 to 7 days and advanced for additional 3 to 7 days before trialing more regular food. And we do discharge our patients routinely with Zofran, PPI particularly for our POEM patients, and then Cipro for several days. And we're continuing to see expanding indications, right, for particularly POEM. The classic indication, type 1, type 2, and absolutely type 3 achalasia with that longer myotomy. But now we're seeing entering more patients for diffuse esophageal spasm, jackhammer esophagus, EG outflow obstruction, failure to prior modalities and re-referrals. And we continue to see this number going up in terms of broad use of endoscopic and third space endoscopy for these patients. But we do need to ensure that with these expanding indications, we're doing the right thing by our patients. Though endoscopic procedures may be the least invasive and they're often preferred by patients, now that we're getting some longer-term data, patients are asking for these procedures, but we need to make sure we're making those right choices. There's also continued ongoing insurance considerations. So we might want to do a GPOEM on a patient. It's not going to be approved from insurance. And so we make sure we're messaging clearly to patients, we're informing patients very well, and that we work very close together between the surgeons and the gastroenterologist to make sure that patients know they're getting the best care and equivalent care. And although it may seem like a long time, but 15 years, we're just at the 15-year mark for POEM. We're barely at the 10-year mark for GPOEM. That's like in its infancy compared to a lot of the surgical things that we've been doing for decades and decades. And so there's still a lot to learn. And there's some long-term outcomes we've yet to basically understand. And so that's just important to share with patients as well. But we're getting there particularly more with POEM and those expanding indications. And part of our practice here is that we're part of a multidisciplinary team. I think a lot of these patients have complex symptom profile diagnoses, and a lot of them now are coming to us. We're seeing increased revisional cases, and so every single week we have a GI foregut multidisciplinary conference to talk about patients like this, where we have our GI motility specialists who you heard from during the duration of this conference, advanced endoscopists, foregut surgeons, radiologists, even thoracic surgeons when needed as well, and that's really, really helpful to ensure sure we have a consensus and we're giving the expert care that patients deserve. It's important that we are part of the body of evidence as well, so that we study our outcomes, which we've done. Dr. Clark has led a lot of those efforts, particularly even a couple years ago, published some of the longest-term data comparing, Heller myotomy compared to POEM as well. And so we want to continue to do that so we can identify optimal patient selection and treatment protocols for these patients. So in conclusion, POEM and GPOEM are overall very safe. They're very effective therapeutic options for various GI motility disorders, and they'll continue to be used and studied. But we recommend multidisciplinary teams with gastroenterologists, surgeons, and radiologists, as that might be optimal for the integrated and successful treatment of these complex patients. Thank you.
Hi, everyone. I'm Pradeep. I'm one of the third-year fellows. I thank the organizers for this invite. Today I'll be talking about image-enhanced endoscopy in some GI disorders. So to begin with, although endoscopy has made a huge stride and we've made great advancements, we see that the colorectal adenoma miss rates is as high as 26% for the early cancer, for early adenomas. And the gastric cancer in its earliest form can be as high as 9.4% to 23.3% in upper GI endoscopies. And esophageal cancer miss rates, early esophageal cancer miss rate can be as high as 6.4% on EGDs. So that's why we need improvements in endoscopy. And one of the improvement in technology is the image enhancement. As the name itself suggests, it's basically enhancing the surface features or enhancement within the equipment to improve the diagnosis of these lesions. If you look at the history of how these has evolved, in the 1970s, it was the era of the fiber optic endoscopes, and we started using the dye-based image enhancement during that period. And there was an improvement in the late 1990s and early 2000s, where magnifying video endoscopes came into being, and again, dye-based endoscopies, chromoendoscopy was used along with it. And in the early 2000s to 2011, there was introduction of the equipment-based image enhancement like the NBI, which was in the earliest form. And along with it, there was high-definition video endoscopes, which we use now. And from 2012 onwards, there has been improvement in the equipment-based image enhancements, as well as we are continuing to evolve and improve the high-definition video endoscopes. So coming to dye-based chromoendoscopy, it basically involves the use of dyes. There are three types of dyes that are used. One is the non-absorptive dye, which is commonly, the most common example is the indigo carmine, which is not absorbed, and it just fills the crevices within the surface and enhances the surface architecture. And in the absorptive sides, it's basically absorbed by the mucosa variably from the lesion to the normal mucosa. The examples are Lugol's iodine, crystal violet, methylene blue, and toluidine blue. Methylene blue is one of the commonly used absorptive dyes, and the reactive dyes, which are uncommonly used, are phenol red and Congo red. Coming to equipment base, I have kind of divided them into three categories based on the mechanism which is used. When there is a manipulation of light, you have examples like narrowband imaging, autofluorescence, or blue light imaging, where the incident light wavelengths are changed in these mechanisms. And in image-enhanced endoscopes, where the reflected light is changed by post-processing process, you have examples like the FICE, which is by the Fujinon, and iScan, which is by the Pentax endoscopes. And where there's a mixture of these two mechanisms, you have an example like linked color imaging, which is one of the more latest enhancements. So I'm just going to concentrate on narrowband imaging. The mechanism is these endoscopes have a filter, which is seen here. And the filter basically cuts off the red wavelengths and only allows the blue and the green wavelengths to pass through. The reason why this is done is because, as you know, whenever there's a neoplasia, the vasculature changes. So this basically to enhance the vasculature. The hemoglobin in the blood vessels have the peak absorptions at the blue and the green wavelengths. So that's the reason why the blue and yellow, the green wavelengths are allowed more in this. And when the blue light hits the superficial capillaries, they are absorbed, and what you see, the vessels become brown in color. And when the green, which has a higher wavelength, has a deeper penetration, goes, and the submucosal veins are absorbed. The wavelengths are absorbed by the submucosal veins, and it appears more bluish in color, basically enhancing the vessels. So because of the paucity of time, I'm going to concentrate on role of image-enhanced endoscopy in Barrett's esophagus, colon polyps, as well as in inflammatory bowel disease. When it comes to Barrett's esophagus, the dye most commonly used is the acetic acid. We basically take help of this phenomena called the aceto-whitening effect, where the mucosa of the Barrett's, if you can see the first image here, it's the high definition endoscopic view of a Barrett's mucosa. And after application of the acetic acid, the Barrett's mucosa turns white because of the aceto-whitening effect, where the mucosa is, the acetic acid is opacifies the mucosa, but it variably opacifies, whereas where the dysplastic area or the early cancers or dysplasias are not taken up. The acetic acid is not taken up by these mucosa and appears variably enhanced. Like here, it is more reddish in color, which gives itself to targeted biopsy. So this is a meta-analysis looking at 9 studies, looking at acetic acid chromoendoscopy in patients with Barrett's esophagus to detect early neoplasias as well as specialized intestinal metaplasia. And as you can see, they have very high sensitivity and specificity. If you look at the pooled analysis, the sensitivity was as high as 92%, and the specificity was as high as 96%, and it had very high likelihood ratio and very low negative reactivity ratio. Now looking at NBI in Barrett's esophagus, these images show high definition endoscopic view of Barrett's esophagus. As you can see, you see that there is a Barrett's esophagus, which is not very clear. Once you switch on to NBI, you can see that the vasculature, abnormal vasculature is very well apparent. In the second example, you can see that there is a nodule, which is kind of appreciated, but really pops out when NBI is switched on, and you can see that there is a variable vasculature here, which leads itself to targeted biopsy. If you look at the evidence, this is a meta-analysis which looked at high-definition NBI, comparing it with a high-definition white light endoscopy. And if you look at the sensitivity and specificity for detection of low-grade dysplasia, high-grade dysplasia, as well as intestinal metaplasia, NBI does a very good job, and the sensitivity and specificities, especially for high-grade dysplasia and intestinal metaplasia, is very high. Coming to dye-based chromoendoscopy in colon polyps. So when you're looking at colon polyps with image-enhanced endoscopy, you look at both polyp detection as well as polyp characterization. For polyp detection, if you look at, there is a lot of studies which has looked at both NBI as well as dye-based chromoendoscopy, and the most common dyes used are methylene blue and indigo carmine, and they haven't found significant benefit when you compare with just high-definition endoscopy. There were some incremental benefits noted with dye-based endoscopy, but they are basically offset by the fact that it takes longer time to complete these colonoscopies. And the strongest evidence for use of dye-based chromoendoscopy are in certain situations like serrated polyposis syndrome, patients who have HNPCC, and on NBI, certain lesions classified as Janet 2B lesions, and who have a risk to assess the risk for deep invasion in them. This is an example where there's a 10 millimeter size polyp in the transverse colon, and it's kind of visible here, but once you put on the NBI, you can see that there is variable caliber vessels, which are seen here, which was correlated to Janet 2B lesion, which correlates to T1A colorectal cancer. But once you put indigo carmine here, these lesions, the pit pattern correlates to VN, which is an invasive form, and that correlates to colorectal T1B, so which on biopsy showed submucosal invasion. So that's the utilization of dye-based chromoendoscopy in a particular setting. If you look at NBI in colon polyp detection, there was a Cochrane review which was done in 2012, which showed that there was no difference between NBI for polyp detection when compared to high-definition white light endoscopy. After 2012, there was evolution of the NBI to the second generation NBI, because the first generation NBI actually curtailed the brightness of the vision. But even with the second generation NBI, they did not show any improvement compared to high definition white light endoscopy. But there was some superior, some of the trials which showed superior detection rate, polyp detection rate, were only with when they had maximal bowel preparation scores. So if you do not have high bowel preparation scores, you do not see good results with NBI. So this is an interesting study which is looking at second generation narrowband imaging to detect colorectal adenomas. They compared academic setting versus community setting, and they found that the academic settings usually outperform the community settings for adenoma detection. And even within the academic setting, the NBI had a higher rate, but although it was not statistically significant compared to high definition. But in the community setting, the high definition white light endoscopy outperformed the NBI, again, but it was not statistically significant. When they compared with NBI experienced operator to non-NBI inexperienced operators, they found that there was a significant improvement in the adenoma detection rate using NBI compared to non-NBI in the NBI inexperienced group. So this is one of the classification systems for characterization of the polyp, which is the NICE classification system. It does not use the magnification endoscopy. It uses the high definition white light endoscopy that we use, and it's basically pretty simple. It categorizes into three types. The first one typified by hyperplastic polyp, which is shown here, and the second by adenoma, and third one, the example being the deep submucosally invasive cancer. So they use the color of the polyp, the vessels, and the surface pattern to characterize them into three types. So looking at the polyp characterization using image enhancement, so the characterization becomes important, especially because for smaller polyps, because then you can use the resect and discard or resect or do not resect strategies. As the name itself suggests, that once you are confident in making the diagnosis, whether it's a hyperplastic polyp, you could just resect and leave without sending it for pathology, or just not resect them and just leave them. For larger polyps, it's important for selection of these patients for endoscopic resection or sending them for surgery. As I mentioned, there are multiple classification systems in use. You should choose one which is which applies to your setting. Like if you have white light endoscopy, NICE would be a better option. And NBI is as good as chromoendoscopy in characterization, except for in the specific situation I mentioned earlier. And if the operator is trained using a training module, it actually improved the accuracy of the characterization to up to 90%. So looking at inflammatory bowel disease, as we all know, IBD patients are at highest risk for colon cancer, especially patients who have primary sclerosing cholangitis. Within the last decade, there's been a lot of debate about whether random biopsy should be done in these patients or targeted biopsies, whether chromoendoscopy should be used versus virtual chromoendoscopy or high-definition white light endoscopy. So to address these, the CNIC guidelines was published in 2015, and it was recently updated based on a number of trials which was done since then. So this is one such study, which was an RCT, which was basically which was comparing high-definition chromoendoscopy to high-definition white light endoscopy, and they found that the dysplasia detection was much higher in high-definition chromoendoscopy compared to high-definition white light endoscopy. And this was another study which was actually looking at the high-definition NBI versus high-definition white light endoscopy. It was a multi-center RCT done in UK, and they found that the neoplasia detection rate was much higher in high-definition NBI versus much higher in the high-definition white light endoscopy compared to high-definition NBI. But the withdrawal time was similar in both these arms. So there have been conflicting kind of results with them. So to summarize all the studies which were done in the last decade, we find that there is a clear evidence for the use of chromoendoscopy when your setting is a standard definition endoscopy, where most of the places in America use high definition, about 77% of them, so it doesn't really apply to us. So chromoendoscopy can be added on to the high definition endoscopy with a little incremental benefit, but at the cost of increased procedure time. At some studies have shown it's up to 20 minutes. And NBI in the current format really doesn't add much to the surveillance colonoscopy in IBD population. And we should use, when you're using high definition white light endoscopy, targeted biopsy, ear biopsy should be done, are sufficient, rather than the random biopsies, except in conditions like primary serosing cholangitis, patients who have a history of colonic neoplasia, or the patient who have a scarred tubular colon. So take-home points are consider using training modules to accustom yourself to the various image enhancement surface anatomy. Consider NBI for characterization of Barrett's mucosa, as well as for characterization of colon polyps. High definition white light endoscopy with targeted biopsies in patients with IBD. This is a link for one of the modules, and yeah, I'm happy to take questions.
Thank you, everyone, for great lectures. And we have multiple questions that were sent to us online. Start with Dr. Esquivel. First question is there still a role for pneumatic dilation for treating achalasia and EG junction outlet obstruction?
Yes, I do think there's still a role, though it is far less common. We actually had another kind of conference now a month and a half ago, and Dr. John Clark convinced me that there's definitely still, no, when you truly look at the evidence, yes, there's definitely still a role, and there's patients that don't want that intervention, maybe don't, need a full POEM or myotomy, and we do see actual decent response rates with pneumatic dilation as well. So yes, there's definitely still a role for that. It does require specialized care as well, right? And so you need providers who are comfortable with that as well, because those can be aggressive, and you should be at a facility that can manage complications or perforations as well.
All right, another question for you. Which patients would not be good candidates for GPOM?
For GPOM. So you saw a few of the contraindications on that one slide for POEM, and those actually pretty much hold true for GPOM as well. As you can imagine, that submucosal tunnel, if you have any sort of varices, if you have any evidence of cirrhosis, if you're on anticoagulation, that's just simply going to be harder to control endoscopically. And so that's going to still hold true for GPOMs, similar to POEMs from that procedural standpoint. It's just a smaller space. And so in that setting, you may, further benefit from a laparoscopic robotic pyloroplasty. Additionally, I didn't go into this too much, but part of what we do here in terms of our kind of practice in terms of seeing who might be a responder to a GPOM is frequently inject Botox into the pylorus, see if there's some symptom improvement. Okay, they're going to be a candidate for GPOM. And I think another reason why multidisciplinary teams are helpful, I also do pyloroplasties, right? And so when you do a pyloroplasty, you are full thickness opening the pylorus, at least 2 to 3 centimeters on the gastric side, through the pylorus, at least 1 centimeter on the duodenum. And then you're doing that longitudinally across that circular pylorus, and then you close it transversely. And so you're really tenting that open. And so, when you during that procedure, we also, we visualize the pylorus endoscopically throughout the duration of the case, and it just dramatically changes the anatomy. So you have a patient who didn't respond to POEM, who has any sort of bleeding disorders. Those are people who maybe you shouldn't be considering a GPOEM for. They're not going to get the response that you need. There's additional studies, and didn't go too much into this in the talk as well, regarding further procedures post-POEM and as well as post-GPOEM. And so, more routinely, we might do another endoscopy and a balloon dilation post-GPOEM. That's not necessarily going to be needed post-pyloroplasty. You just completely change the anatomy. Those circular muscle fibers of the pylorus are no longer in relationship, and so it's a bit more oblique. So, in those settings, if you don't think you're going to get a response, you're less likely to move forward with a GPOEM and consider another intervention.
You mentioned, this is a related question, you mentioned that Botox injection, response to Botox injection might be a predictor for response to GPON. Does FLIP play a role in predicting response as well?
So I found we actually used to do, and Juha, I think, you can correct me if I'm wrong, he stopped using FLIP as well for GPOMs. And I'll say, I think it's, you need a minimum pressure of 15. You can sometimes be hard pressed to do that when you have part of the catheter in the stomach and the other part of the catheter in the duodenum. And so it's a bit less reliable in terms of guiding if you're going to have a response. I don't think that you can follow those numbers routinely. And so I don't plan to use that routinely in my practice in determining who's going to be a responder or not responder with the current use and data that we have now.
There's a very passionate question here, and I think it's out of despair treating patients with gastroparesis. The question is, why don't we treat everybody with gastroparesis with GPON?
I'm going to defer to some of my GI colleagues here. No, just kidding. It's an intervention, right? And so it's, I think from the procedural standpoint, yes, it's overall very safe. Yes, we can see some good outcomes, right? But patients are under general anesthesia, so other contraindications include contraindications just to that in general. What is their cardiopulmonary status, their general health status? What is their ability to follow post-procedure protocols? So it's an intervention. So when you think about these patients, it absolutely, regardless of GPOM or not, should be very integrated care. And so usually it's a stepwise progression. There should not patients be really coming into our clinic from the procedural standpoint for myself or other advanced endoscopists, from the surgical standpoint or GI standpoint, who haven't been optimized and fully worked up, and that's going to need to continue post-procedure either way. So if patients are getting some symptom improvement or management with medical modalities and behavioral changes as well, that's going to be really important for them. And so, I think it's overall safe, but it's absolutely an intervention and it shouldn't be the knee-jerk for all patients.
Great. Well, thank you. All right, so moving on to questions. I don't know why the questions just disappeared from my screen here. But there was a question about which hospitals in the Bay Area perform EUS-guided gallbladder drainage. I mean, we do. The video that you saw is from our facility, from one of our procedures. I don't know about other facilities. There was another question related to sphincter foramen dysfunction and if we still using biliary manometry for sphincter foramen dysfunction. Is it still a viable test to look for that? It's really hard to reproduce data from biliary manometry measurement. And with a drop of type 3 sphincter foramen dysfunction, where we don't really believe that entity exists, and it's mostly like functional. Patients with type 1 sphincter foramen dysfunction are usually treated with biliary sphincterotomy from the start. These patients have dilated biliary tree, that biliary type of pain, and elevated LFT, so we straight do biliary sphincterotomy for these patients. For type 2, where you have 2 out of the 3 present, that's where the tricky part is. And if some institutions do still do sphincter foramen manometry to determine if it's elevated and treat based on that, we do rely on the clinical presentation. If there's elevation in LFTs, especially if it's intermittent, transient, along with biliary type pain, we do perform ERCP right away. Sometimes we add HIDA scan to check and see if there's suggestion of sphincter foramen dysfunction in these patients. But again, the data of using HIDA scan for that is also not great. If there's elevation LFTs in type 2, then we proceed. And if there's just dilation and biliary type pain, we usually counsel the patient and see if there's any other reason for their pain. And if not, then we counsel them about the ERCP. Yes, sir.
Yeah, there is a fairly high incidence of post-procedure pancreatitis with biliary manometry. So we did some while I was in Southern California, but we had to be very careful in or leave the pancreatic stent
Mm-hmm.
after the procedure?
Absolutely. So this the comment was there is a high risk of post-ERCP pancreatitis or post-biliary manometry pancreatitis, and you used to leave a pancreatic duct stent to decrease the chance of post-ERCP pancreatitis. Yes. So this intervention is associated with that. So sometimes you weigh the benefit and risk, and going directly towards a sphincterotomy sometimes might be the way to go. The question is, do we need to do biliary sphincterotomy along with pancreatic sphincterotomy? Studies have shown that it doesn't matter if you do dual or just biliary. So it's limited to biliary, but definitely in these cases, you have to place a prophylactic pancreatic stent. All right, so. Yes, I can see them now with my eyeglasses, yes. Dr. Fernandez-Becker, how long do you recommend gluten challenge for celiac serology versus biopsy?
So in terms of the gluten challenge, the bottom line is like the longer, the better. You could see mucosal changes as early as 2 weeks after the gluten challenge. And in general, you could start with 3 grams of gluten a day, which is what the current guidelines recommend. And assessing at 2 weeks, if the patient is still tolerating it quite well, then recommend going at least 4 to 6 weeks. You see mucosal changes as early as 2 weeks, but the serology doesn't become positive until about 4 weeks. So if you do it only for 2 weeks, you miss a lot of patients.
Great. And which assay do you recommend for checking TTG? Any specific assay?
It kind of depends on the institution. For us, we have what's called FADIA, which the normal value is less than 8. But at PAMF and at Kaiser, there are different assays that are used. The reason why we switched from what we used before is because we were getting children with type 1 diabetes are screened for celiac disease, and there were a lot of false positives with the previous test. And this one performs better.
Great, thank you. If biopsies only show elevated intraepithelial lymphocytes, what's your approach?
So that's nonspecific. And I think that's where you have to rely on the serology and the clinical picture. We see increased IELs in SIBO and IBS, and it really is something that has to be interpreted in the context of the clinical picture.
Great, thank you. So what's your biopsy protocol? Like, what do you recommend? D2, bulk biopsies?
So what's recommended is it's a patchy disease, so you want to take multiple biopsies. And what's recommended is 4 biopsies in the distal duodenum and at least 2 in the bulb. I was trained in Boston, and they ingrained in me 6 biopsies in the distal duodenum, and I still do that. And I also like to put them in separate bottles for the simple reason that in the duodenal bulb, there's a lot of Brunner glands, and it distorts the villi. And an inexperienced pathologist can overcall that as villus blunting. So I prefer to have them in separate bottles, and there's more specificity for mucosal changes in the distal duodenum.
Great. Any questions from the audience? Yes, sir.
I'll push a little more on the GE poem gastroparesis question. And there are some centers who are now going directly to GE poem with a gastroparesis 4-hour study. And the argument that's being made is that safety is pretty good. 70% response rate, at least in the first year, looks pretty good. We don't have any meds which right now are FDA approved besides Reglan. Tons of downsides with it. We know medical therapy doesn't work well. So in these people who, well, let's say are idiopathic and they're 30 and they're young and otherwise pretty healthy besides gastroparesis, which is debilitating, do you think it's wrong for people to be going straight to G-POM-B before doing the trials of tricyclics and Buspar and Botox and all of these other things that we do that don't always seem to work that well?
No, absolutely. And I thank you for pushing back on that, because I do think, that's where things are going, right? G-POM is technically, in my opinion, in its infancy, even though the first procedure was done a decade ago. In terms of its broad applications, even here at Stanford, we're several years in, right? So that's really, really recent. But I would say, so that's where the practice is going, right? And that's, as I mentioned, when patients don't get approved for G-POM, right, because basically really focusing on treating the pylorus, that door was further opened with a really minimally invasive endoscopic approach with the G-POM. And we're seeing really good outcomes from that, even in the short term, in several year outcomes. And so I think that is where things are going. I think that's where the referral patterns are going. I think that's almost an expectation. Patients have a diagnosis. Okay, let's link you up with someone who can help treat your pylorus, right? Pyloric-directed therapy. And that's actually having implications for our surgical practice as well, because these patients aren't all getting approved. So we're doing more pyloroplasties than we were ever doing even a decade ago, because we're saying, okay, well, let's get more aggressive with this, right? Let's not just let patients suffer. So I think you're exactly right. I think it's a very safe procedure. I think there's going to be very low risk. I do think that even patients that may not respond to Botox, there's still Botox compared to a G-POM is still going to be a more benefit with a G-POM. So you might see some improvement there. But, again, if we still have continued insurance issues, treating the pylorus surgically is also overall a very well-tolerated procedure as well, that I think in terms of quality of life is still risk-benefit going to be something to be on the table for these patients, even if they don't qualify for G-POM.
Do you think dumping or any downstream issues are things we'll have to worry about like 5-10 years down the road?
I think less so with G-POM, just because you don't distort the anatomy so dramatically, and so I don't think you're going to see that. And we, even anecdotally here, haven't been seeing that too dramatically. I think technically with pyloroplasty, maybe a little bit more because you distort the anatomy much more dramatically. But for these patients, when we even discuss some of this kind of risk benefits, what's that going to look like for you? They still dramatically are like, I will take that risk based off of what I'm living through 24/7. So we will, I think, again, part of the reason this is technically we're going to have a lot more data in the next couple of years because the volumes are going through the roof for both of these procedures.
Cool. Thank you.
Thank you. Mike, a question about the rigidizing tube. Which cases do you think are contraindication to perform or use the rigidizing tube?
Yeah, good question. So in terms of FDA approval, I think the one thing that I do note is that it's not FDA approved for patients who've had belly surgery. And so definitely for patients who've had recent belly surgery, I would not consider it. Remote history of belly surgery, I think twice about it and definitely have a longer conversation with patients if we are going to do it and describe that it's not actually FDA approved for that indication. In terms of other things that we think about, I think it's important to think about what makes the rigidizing overtube most useful. It's definitely in cases where you're trying to reduce looping. So for patients with tortuous colons, the rigidizing overtube is not necessarily going to be the tool of choice because the issue here is not a looping issue. And so I think that's another place where I would think twice before doing it.
And so when you're saying tortuous colon, you mean that there is a sharp angulation, there's a fixed sigmoid,
right,
compared to the looping of the colon.
Exactly.
That's where the rigidizing tube is very helpful in those cases.
Yeah, where there's a lot of a fixed colon with a lot of angulation. I'm not sure, I don't actually think the rigidizing overtube is great in these particular cases. One, because you've suddenly increased the diameter of the tubes that are actually going into the colon. So I think the other side point to mention is the current, most rigidizing overtubes that are available right now by Neptune are accommodating the PCF enteroscope or the EGD scope. There is a variant where it's accommodating the CF scope, but most practitioners use the variant that's a little bit smaller diameter. Because of that, either way, you're increasing the diameter of whatever is going in through the anus. And so I do think for patients who have more tortuous or angulated anatomy, I'm not sure if I would start with the overtube.
Great, thank you. Pradeep, why do you think, what do you think needs to be done to promote the adoption of chromoendoscopy in the U.S.?
I think most of the studies where chromoendoscopy has been used has magnification endoscopy as well. That's one thing. And I think it should be employed in tertiary centers, which are like if they're dedicated facility which is using Barrett's esophagus or something, then you could do it. But the role is actually decreasing. I think with the advancement of equipment-based image enhancement, I think the role is decreasing. There are specific conditions, like I mentioned, where it can be useful. And if you are such a high care center where you see that kind of numbers, that can justify it. But for a regular practitioner, I don't think it really is cost effective to have that because it increases the time. You need a special equipment. And also training.
Thank you. One final question to Andrew. Andrew, it seems that there is a room for a study using fluid in preventing post-ERCP pancreatitis. I wonder why it wasn't done yet. It's easier to give the fluid like shortly during recovery than just giving it over 8 hours or admitting the patient for further fluid. Why do you think that's the case?
No, that's absolutely true. Yeah, that's absolutely true. I think, if you look at the RCTs that were included in the systematic re-meta-analysis, I think all but one were an 8-hour or longer study, and only one was a 2.5-hour study. And, for outpatients, obviously, an 8-hour protocol is impractical. So I think it's an obvious area of further investigation. And I think there actually are some studies ongoing looking at these shorter duration protocols. In terms of reasons why, I think it may have just been an ease of study design. If patients are already admitted, you're not really constrained by this 2-hour limitation or 3-hour limitation recovery. And, I think if you're hoping to see kind of some effect size, I would assume that a longer infusion is probably where you start, as that's how we treat most pancreatitis from other causes.
Yeah. And it's also probably trying to use the same protocol that's used for acute pancreatitis treatment, where it's shown to be effective in some of these studies. All right, great. Well, thank you very much, everyone.